Greetings from Southern California. I'm going to be talking to you about cochlear implants in older and misdiagnosed patients. We know that hearing loss in infants and children is a neurological emergency, so we advocate for newborn hearing screening with the goal being to identify and begin the intervention process at birth to minimize the delays caused by hearing loss. About 1 to 3 per 1,000 babies will be diagnosed with hearing loss, but another 3 by the age of 18 will have been diagnosed with a permanent sensory neural hearing loss. And it's those children that we want to talk about today. So what can cause hearing loss in our older pediatric patients? I think it's important to realize that we have 3 different categories that these hearing losses fall into: late onset and progressive, acquired, and missed or misdiagnosed. So our late onset or progressive hearing loss patients can have a variety of etiologies. We know that congenital CMV is a major cause of late onset or progressive hearing loss. We also know that anatomical differences like EVA, Mondini's deformity, and common cavity can cause progressive hearing loss. There are also a number of genetic syndromes and some genes which are associated with late onset or progressive hearing loss. Acquired hearing loss comes from disease or injury. We know that meningitis is a major cause of acquired hearing loss, and the highest rates of infection of meningitis are in infants and adolescents or young adults. So it's important for young adults in college age who are going to be living closely together to be vaccinated. Acoustic neuromas can lead to acquired hearing loss. We know that ototoxic medications, especially those associated with chemotherapy for childhood cancer, can lead to hearing loss, especially those children treated with cisplatin, carboplatin, and radiation combined. Head trauma can also be a cause of hearing loss in children, and we're seeing an increase in noise-induced hearing loss because of personal listening devices. What can lead to our missed or our misdiagnosed patients? Well, our missed patients are those who did not have newborn hearing screening or who had a false negative response on their newborn hearing screening. Our misdiagnosed patients are those who, because hearing loss looks like so many other traits or disorders, that their personality, articulation, language, attention, behavioral issues, cognitive issues, or inability to connect socially, that those traits or disorders are seen as a function of something else and not hearing loss. It's so important that hearing be evaluated first before we consider other types of disorders in children. So what are the characteristics of our late onset, our progressive or acquired hearing loss patients? Well, most of these patients had normal hearing or near normal hearing, so they are using spoken language and they want to continue using spoken language. They are learning language, acquiring vocabulary, they're sitting in academic and extracurricular activities, so they spend their days in challenging listening environments. They want to socialize, but they're struggling to keep up academically and socially. So when do we consider cochlear implantation for these patients? From a medical standpoint, their health needs to be stable, and we need to have the imaging completed to ensure that they are candidates for cochlear implantation. From a speech, language, and academic standpoint, as soon as a plateau is noted, we need to begin considering whether they need additional help through cochlear implantation. We do not want to see regression in any area. And we also need to watch because for these children, hearing rather than learning becomes the focus because hearing takes such a cognitive load for them that they don't have a lot of energy left over for learning. From a social emotional standpoint, this is an ongoing conversation with the patients and their parents. In the United States, we have the Food and Drug Administration guidelines. For adults, they say that cochlear implantation should be considered for a moderate to profound sensory neural hearing loss, and when open set speech recognition for words is below 60% and sentences below 50%. For children aged 2 to 17, the FDA says a severe to profound hearing loss with limited benefit from binaural amplification and open set speech recognition less than 30%. I do want to make two notes about our English testing versus Spanish testing. The first is that in English, we use monosyllabic words, whereas in Spanish, you use bisyllabic words. This means that your testing is actually a little bit easier than our testing. So children with the same hearing loss in Spanish would be expected to have a little bit higher speech perception score than our children in English. So we may need in Spanish to consider cochlear implantation, say at 70% rather than 60%. Also, for sentence testing, I'm happy to report that the AZ Bio sentence test is now available in Spanish. So for children who are aged 2 to 17, it's important to know that the recommendation of implantation at a severe to profound hearing loss is based on a 95% confidence interval that these children will perform better with a cochlear implant than a hearing aid. But there's a growing body of literature to suggest that we should be using a 75% confidence interval, which means that at a moderately severe to profound hearing loss, these children will do better with a cochlear implant than a hearing aid with 75% confidence. And we have had literature to support this since 1997 when Arthur Boothroyd found that children with sensory neural hearing loss, if they're using spoken language, will do better with cochlear implants at a hearing loss greater than 70 decibels. And I've listed several resources for you there that show that at about 65 to 70 decibels, we should be looking at cochlear implantation. So why is 70 decibels this miracle number or the magic number? Well, first, there have been researchers who have proposed that at 70 decibels, the damage to the cochlea is such that at that point we have cochlear dead regions that may not be able to accurately transmit the information. It's also important to understand the dynamic range of hearing. So for those of us with normal hearing, say starting at 0, sound is very soft, it grows to a comfortable level, eventually to a loud speech level, and by about 90 decibels, it becomes uncomfortably loud. So we have a large 90 decibel dynamic range of hearing. For someone with this hearing loss that I've plotted here, a moderately severe to severe hearing loss, this is where their threshold is, where they begin hearing. And by about 90 decibels, sound will become uncomfortably loud for them too. So a hearing aid is required to smash our entire 90 decibel range of hearing down into this very small 20 decibel or less range. Hearing aids have a really difficult time doing this. And so the first thing that becomes sacrificed is the access to soft speech. And soft speech is incredibly important for children because this is how they overhear social conversations and how they overhear information that they need to learn. It's estimated that children learn about 80% through incidental listening. So without the access to soft speech, they don't have access to incidental hearing, and it affects their learning and socialization. Turning up the hearing aid to increase the amplification is not going to help because that's going to lead to distortion and possibly discomfort. So I would argue that our older patients, our older pediatric patients with progressive, late onset, or acquired hearing loss are more like our adult patients. And we know that duration of hearing loss is negatively correlated with the results of implantation. So these children with hearing aids should be implanted as soon as deterioration is noted in their hearing and speech. Is rehabilitation going to be needed for these patients? Yes, but it should be short term. Rehabilitation should ensure that all that there are appropriate expectations, and all professionals involved should be reinforcing those. We should also Rehabilitation should be ensuring appropriate cochlear implant programming follow-up and auditory verbal therapy, which can be done by a trained listening and spoken language specialist. And also these patients can use the manufacturer's rehabilitation programs that they provide. But what about the characteristics of our missed or misdiagnosed patients? Well, these patients are going to have a wide spectrum of characteristics. They may have had some hearing that that went undiagnosed for a long period of time as it progressed. So they may have speech and language, and they may have fairly normal social and behavioral skills. Or they may have absolutely no speech and language, and they may have inappropriate social and behavioral skills because the intervention they have been provided because of misdiagnosis has been inappropriate. So when do we consider implantation for these patients? Well, time is of the essence. It's not these children's fault that their hearing loss was not diagnosed or it was misdiagnosed. We feel that every child has the right to hear. And so once their hearing loss is approaching that magic 70 decibel level, it's important to consider implantation and not spend a lot of time with hearing aids. But a strong team has to be in place, as rehabilitation for these patients is going to be extensive. So what results do we get for cochlear implantation with our progressive, late onset, and acquired hearing loss patients? Well, improvement should be rapid with commitment and appropriate rehabilitation. Seattle Children's looked at patients that they implanted with steeply sloping sensory neural hearing loss, and 1 month post-activation, their open set listening had increased dramatically. We have also found speech perception benefits. We have found that patients may talk about sound quality differences with the implant for the first couple months, but even reporting sound quality differences, open set listening we have seen as early as the day of activation, and generally by 1 month post-implant. Most of these patients have completed their rehabilitation by about 3 months post-implant. But on top of just speech perception benefits, there are a lot of other harder to quantify benefits. It is much easier for these children to listen. And because of that, parents and teachers often report personality changes. It is basically that it is easier to socialize, and so these children have much more confidence in interacting. We've seen improved learning reported. Generally, we think that's because these children have less cognitive fatigue and more ability to remember. Improved attention, because it's easier for them to follow conversation, so they're less fatigued and they have less of a need to check out. But we do have some patients who feel that they heard everything before they were implanted because they did hear everything that they heard. They had no idea what they missed. And they still don't often recognize how much more they're hearing with the implant. I wanted to share with you a text that I received from one of our patients who has a moderate to profound sensory neural hearing loss, went through his education at highly academic schools with hearing aids, and a year ago was implanted. And this is what he wrote. Today marks 1 year since I had my implant surgery, so feels like a pretty big day to me. Been reflecting a lot on what this implant means to me, and I feel there aren't enough words to describe it. I must say choosing to have the surgery was the best decision I've ever made. And now listen to the things that he reports that he's able to do that he couldn't do before. From being able to converse with people I likely wouldn't have been able to hear well before, to hearing a friend say something to me 20 feet away, to driving my car and having a conversation with someone in the back seat, to being able to listen to the radio, to being able to hear work conference calls, to being able to totally get by in this entirely masked world, and most importantly, this new tremendous sense of confidence I have engaging with the world. Going into surgery, I didn't think the results would be that different from hearing aids. But now thinking about going back to just hearing aids feels scary and unpleasant. I shared this text with another college age pediatric patient who has always been told by her audiologist that she does well enough with hearing aids. And she actually started to cry and said, I haven't been able to do many of these things. I really can't believe that someone could with an implant. So I think that, again, we need to look carefully, not just at numbers on a graph, but at what these patients are able to do. So what about the results for our missed or misdiagnosed patients? Well, research shows that benefit is going to correlate with age of implantation. And we know that the best outcomes are before 12 months of age. Obviously, if these children's hearing loss was missed or misdiagnosed, we're not seeing them before 12 months of age. But research also shows that speech perception and mainstreaming is better if we implant before age 5. And there's even been research to show that prelingually deafened patients who did not get implanted until late, age 13 to 30, still reported significant improvement in communication 1 year post-implant. Benefit also correlates with hours of use, so all waking hours is incredibly important for this population. Communication mode is important. Use of spoken language must be the goal, or at least a combination with spoken language to get true benefit from the implant. Patient and family and motivation is important, and also additional challenges like health or developmental issues may impact benefit. However, we have seen that traditional benefit for our missed or misdiagnosed patients does not necessarily measure the psychological benefits, the mental health benefits, and the quality of life benefits that these patients and their parents report. And to encourage you, I would like to share with you this video of one of our misdiagnosed patients. This child, his mom became concerned about his speech and language development when he was a year old. Because he had passed his newborn hearing screening, he was referred for autism testing rather than a repeat hearing test. He then had 4 years of intervention for children on the autism spectrum before at age 5, it was realized that he had a severe to profound hearing loss and not autism. He spent another year before the team agreed to implant him. So he was 6 when he was implanted and had no spoken language at that point. Here he is at age 7, 1 year after implant. He is celebrating his 7th birthday and his 1 year anniversary of his cochlear implant. And I want you to listen to him singing happy birthday.
Birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday to you. Very.
So I would suggest that with intensive habilitation, our children who are misdiagnosed or missed can still make significant progress with cochlear implantation. Then I have a number of resources also to share with you that are in my slides. Thank you.